Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillahir Rahmanir Rahim. I'd like first to acknowledge all the staff members of Department 9 for this nice effort. And special thanks to Dr. Mohamed Abu Saud. This is me, Mohamed Youness. I'm going to discuss with you traumatic hip dislocation together with the fracture head femur as a part of our postgraduate orthopedic review course. We start with discussing our learning objectives. We are going to discuss each topic through its incidence and classification, proper assessment of the injury, together with the management plan, and lastly, the outcome expected from such an injury. We start with the traumatic hip dislocation. It's a rare condition, it's a rare trauma. This is because the high stability of the hip joint. The hip joint is the most stable joint in our body. This is due to its bony configuration, the stable head inside the acetabulum, the bone conformity, in addition to the soft tissue stabilizers through labrum, strong ligaments surrounding the hip joint, and even strong muscles surrounding such a joint. This justifies why, when we have such an injury, especially in young patients, young adults, it's due to a very violent trauma, extreme violent trauma. So we expect associated injuries with such an injury. The prevalence of non-orthopedic injuries in hip dislocation is about 67% of the number of hip dislocations are associated with other injuries, with other non-orthopedic injuries. About 24 of them associated with a closed head injury, 21 associated with a craniofacial injury, and 20% associated with thoracic injury. Then, how to classify such an injury? The first classification is to compare between just a mere dislocation, which is a simple dislocation with no other association, or complex associated with other fractures. Or we could classify the dislocation according to the direction of the dislocated part. The most common type is a posterior dislocation. About 90% of the dislocations of the hip are posterior. The head, as you could see in the diagram, migrates superiorly, posterior superiorly, and appears at the upper limb of the margin of the acetabulum. Such an injury occurs when the impaction occurs to the hip while the hip is in internal rotation and adduction. So the head is pushed away from the acetabulum posteriorly. The other type of the dislocation, according to the anatomic classification, is the anterior dislocation. And the anterior dislocation, the head is pushed medial or inferior to the acetabulum when the site of infection occurred on the hip while the hip is in external rotation and adduction. When the head is migrated while the limb is in extension, so we expect the dislocation to occur superior towards the pubic bone. Or when it occurs while the knee is flexed, we expect the anterior dislocation to occur inferior towards the obturator foramen. This is a very, very rare case where we have a bilateral hip dislocation. One side, the hip is dislocated posteriorly. On the contralateral side, the hip is dislocated anteriorly. Other classification is the Levin or the Thompson-Epstein classification. It classified the dislocation according to main points, which are the the dislocation and the association, in addition to the stability post-reduction, whether we have stable reduction or unstable reduction. So in type 1 and 2 level and in Thompson-Epstein type 1, we have mere dislocation without any associated fracture, and we could perform a stable reduction. When we go to level type 3, we have a non-congruent reduction. So in a stable reduction, and we haven't got any other bony fractures. In level type 4 and Thompson-Epstein 2, 3, and 4, we have a dislocation in addition to acetabular fracture. In level type 5 and Thompson-Epstein type 5, in addition to our dislocation, we have a femoral head dislocation. What we expect after hip dislocation? What is the presentation of such a patient? We'll start with the symptoms. Symptoms, we will have ecchymosis, pain, swelling, in addition to loss of function, and the deformity. The deformity will help us a lot to expect the direction of the dislocation. When we have an internally rotated, adducted, shortened limb, we expect a posterior hip dislocation. And we have externally rotated, adducted limb, we expect anterior dislocation. So during physical examination, don't forget, such poor patient has got its injury, his injury from a violent trauma. So don't forget to address the patient first before going to the injury. You should keep the patient alive through addressing the basic life support protocol for such a patient before you examine the affected limb and the injury itself. As we said, in posterior dislocation, we expect the deformity to look like what we have discussed, the internally rotated adducted limb, and the anterior dislocation, the opposite, the external rotation, external rotated abducted limb, according to the direction of the migration of the head after the injury. We will go through our diagnosis. We will discuss the imaging techniques. First, we will discuss the X-rays. When we have got any AP view, AP hip view, we will have to delineate some lines to get sure that we have a congruent or a dislocated joint. We have to check for the iliopectineal line, the ilioischial line. We have to check for the roof and medial wall of the acetabulum, the anterior wall and posterior wall of the acetabulum, together with the congruency of the head together with the acetabulum, and follow up the joint space all around the hip joints. So we'll do an AP view and the cross-table lateral view. We don't mobilize the injured limb. We mobilize the source of the X-ray. So we will get a cross-table lateral view. After reduction, you could do more special views to evaluate the whole case, like inlet-outlet views and special oblique Jode views. What are we search for? First, the congruency of the hip joint and the joint space. To check the congruency of the hip joint and check that the head is fitting inside the acetabulum. Second, we have to check for the gentle line passing through the inferior part of the neck together with the inferior part of the superior pubic ramus. Then, in case of anterior dislocation, what do you expect? You expect that you look to the head, you find the head on the dislocated side is bigger than the contralateral side, unaffected side, because it's much more nearer to the source of the X-ray. And you find it medially or inferior to the acetabular cavity. In case of the posterior dislocation, you will find the head looks a little bit smaller than contralateral side, together with the position of the head is posterior superior to the acetabular. This is the X-ray. It's a very nice X-ray showing both posterior dislocation of the hip on one side, and on the contralateral side, anterior dislocation of the hip. What to do next? Most of cases, or nearly all of cases, you have to evaluate the case more by doing CT. CT is very useful in detecting the direction of the dislocation. Sometimes the radiograph is not enough. Sometimes you'll get tricked with the radiograph. So you have to do a CT to check the direction of the dislocation, whether it is anterior or posterior dislocation. In addition, you could judge more the joint line and the congruency of the joint, or if you have incarcerated fragments or loose body inside the joint itself. It's very important to evaluate associated fractures. You can manage without full evaluation of the whole case with the dislocation and the association with the dislocation. In addition, it's very crucial to check post-reduction CT in case you haven't got the congruency you desire. You have to check after the reductions that you have achieved the goal for a congruent joint after your reduction. You have to do a post-reduction X-ray. This is also a very interesting case where there is a bilateral hip fracture with one side posterior and the other side anterior. MRI. MRI is not usually used in case of the initial assessment of hip dislocation. It's an investigation which is useful to evaluate the sequelae of the hip dislocation, to evaluate the labrum, to evaluate the cartilage, to check the vascularity of the head of the femur after the dislocation and the reduction of the procedure for correction of such an injury. This is an MRI image showing a head fracture after reduction of the head fracture found evaluated or found after the reduction of the hip itself. What are we going to do? What is our management plan for such an injury? The initial management is very important. To evaluate the case and to do a proper initial management, it's a must to get a well patient or with the least complication after such an injury. You have to do emergent closed reduction. It's much more better to do it within the first 12 hours. Any delay will make your prognosis worse. Then the definite management, when you can't achieve a concentric stable reduction, then you'll move to the second point, which is open reduction. So when we are obliged to do an open reduction, the indication is irreversible irreducible dislocation. You have to go through open reduction. If you have got an incarcerated or a loose body inside the joints, if you get delayed presented cases, and lastly, when you haven't achieved your goal, when you have a non-concentric reduction. Open reduction and internal fixation it's very important in cases with fracture dislocation hip. You have to address the associated injuries, whether it's a fractured neck, femur, or a fractured acetabular. Arthroscopy is very useful in cases of loose bodies or incarcerated fragments which are small and could be removed by arthroscopy after closed reduction. Closed reduction has many maneuvers, but the principles of closed reduction is first to do a traction counter traction to pull in line with the deformity itself until you disimpact the two articulating surfaces. Then you counteract your deformity to get the head inside its acetabulum. Many maneuvers are discussed, like the Alice maneuver or the Stimson technique. What are the expected complications from such an injury? First of all, is post-traumatic arthritis, which can occur up to 20% of cases. Then the osteonecrosis or femoral avascular necrosis, which could occur up to 40% of cases, and it's quietly linked with the time elapsed till you get a proper reduction. Site nerve palsy, which occurs mainly with the posterior dislocation. It could occur up to 20% of cases, and a very rare complication is a recurrent dislocation, which could occur in 2% of cases. Then we will discuss the femoral head fracture. Also, it's a rare incidence. Just 5 to 15% of posterior dislocation could be associated with femoral head fracture. What is the possible physiology? We are expecting head fracture to occur, whether as impaction or even avulsion, or shear forces, with the shear forces of the dislocated hip, the pulsoanatomy, or the size or direction of the fracture depends on the position of the limb or the head in the pre-injury state. How to classify such a fracture? The most popular classification is the Pepkin classification. It's classified into 4 types. Type 1, you have a small fragment inferior to the attachment of the ligamentum teres, which is the fovea. It's away from the weight-bearing area, like you could see here in such X-ray. Pepkin type 2, it's a larger fragment above the attachment of the ligamentum teres, and you could see that it's very near to the weight-bearing surface of the joint. Pepkin type 2 is an association of Pepkin type 1 or 2 with fracture neck femur. So it's Pepkin type 3, and it's very important because it has the highest incidence of avascular necrosis post-treatment. Pepkin type 4, it's a Pepkin type 1 or 2 associated with fracture acetabulum. How to manage such a fracture? First of all, yes, we have a room for non-operative treatment. Reduce the hip closely, get it stable, concentric reduction. You could adopt conservative treatment, especially in Pepkin type 1, or in other place Pepkin type 2 with a step of less than 1 millimeter. If you haven't got any interposed fragment or loose body, if you can get a concentric stable hip reduction, you could do a conservative treatment. Other than that, you have to do an open reduction internal fixation, whether through an anterior approach or medial approach, or even do a trochanteric trapezotomy when you have a step more than 1 millimeter, loose body or cessation, like fracture neck femur or a fracture acetabulum in cases of polytraumatized patient or irreducible fracture dislocation. You have to go through open reduction and internal fixation. Other than that, you could do arthroplasty, especially in old patients with porotic bone and comminuted fractures. You could go through arthroplasty when you are beyond the possibility of reconstruction. Arthroscopy can be done in some cases where you could get rid of loose fragments or incarcerated fragments. In such an injury, you could get a heterotrophic ossification, which is more common in anterior approaches than posterior approaches. And its overall incidence is ranging from 6 to 60% of all cases. Avascular necrosis could occur in 20% of cases. Sciatic nerve neuropraxia could occur in 20% of cases. Degenerative joint affection or osteoarthritis could occur in 8 to 75% of cases. Decrease in tenuation may be insignificant and doesn't affect the function in some cases. Take-home message: avascular necrosis is strongly correlated to cases with dislocated hip with longer time elapsed till reduction. Proper radiographic evaluation and assessment of cases of hip dislocation is very important, crucial for proper management. Femoral head fracture in many cases requires CT evaluation first before you go for surgical planning. Treatment of femoral head fracture depends on its size, location, and its proximity to the weight-bearing area. Thank you for your listening.